This is our last panel before we again have a discussion with policymakers, and hopefully we have a subject of interest to all of you. It's healthcare reform and health. And to set the stage for this, and again, if you have been alive over the last couple of years, you know there's been a lot going on in healthcare reform. My dream last night actually had this session taking place in January of 2015. And the nice thing about 2015 is that we'll know a lot more answers to questions relative to healthcare reform that quite honestly we can speculate about today, we can think about, we can talk about, but we quite honestly will not know how some of these reforms will actually be operational until 2015. As you know, we have federal overlays and we have state overlays, but the interesting thing about healthcare is that healthcare is delivered locally. And our panelists today, I think, will give you a unique perspective as to how we're looking at that relative to Jackson and Josephine County. So I'm thrilled to have Roy Vineyard, the CEO of the Asante system, and Ann Alftine, who is a physician who lives in our community but has been spending the last couple of years on a unique journey relative to the Jefferson Regional Health Alliance, and particularly over this last year, her involvement with these new entities called CCOs, Continuing Care Organizations, which is a new way that we'll be actually delivering healthcare in our valley. I think the one thing that we wanted to also just touch on was the fact that within the state of Oregon, there is a lot of activity going on right now. You've heard about it probably this week relative to our perspective on what's called the healthcare exchange. In Oregon, we're going to call that Cover Oregon. And basically, it's going to be a way for individuals and small employers to be able to access the health insurance industry and different types of products. But I think it's important to remember that within the state of Oregon right now, that the state of Oregon purchases around 20 to 25% of all health care that's paid for in the state of Oregon. And so it's a huge player through our state employees, through our government employees, and particularly through the Medicaid population that is eligible to get health insurance and health insurance subsidies through the state of Oregon from federal resources and state resources. If you had a chance to look at the governor's proposed budget for this coming biennium, look at the Oregon Health Authority. $8 billion is what is being budgeted for the next biennium just in the Oregon Health Authority. So we're talking about a huge impact relative to what is purchased, how is it purchased. I had the privilege of chairing the Oregon Health Fund Board, and at that point in time, before we went into the recession, about 12 to 15% of all Oregonians had no access to health care insurance. Well, the recession ramped that up to between 15 and 20%. So we have a situation today where over 600,000 Oregonians don't have health care insurance. And the reality is we're embarking on a process where many of those folks, for the first time, will have access to health care insurance. How can that be? Well, that can be because of subsidies. And that means transfers, supports, depending on family income, to be able to access health care insurance. The exchange in its simplest form is something that we could probably do very easily through just the existing private industry base and using the internet, working with our local insurance brokers and having access. The dilemma, the challenge though, is how do you deal with, in essence, this huge population who requires and deserves different subsidies depending on family situations, economic situations, and how do you make this thing work operationally? Because again, you're talking about a tremendous amount of money. So the Oregon Health Exchange, Cover Oregon, we have had the advantage of tremendous input by both Oregon Health Authority and the insurance division relative to how to set this up. Rocky King, who is in charge of this right now, probably knows as much about it as anyone in the United States. And we're gearing ourselves up starting in October 1st of 2013 to be able to offer health insurance access through this whole new model. There are unbelievable questions that are being posed and need to be resolved as we move forward. And again, hopefully we know that the legislature will be there answering and adding input in on the health exchange as we move through this session. But at the end of the day, for the residents of the Rogue Valley, think of a time where insurance is truly portable. Think of a time where families can be able to plan on long-term health improvements based on the fact that they have access to a family physician, that they have access to the type of care that they need. So I am really, really excited about where we're going. One quick other overlay at the federal level, and then we're going to hear what does this mean in our own community, through our own health system, and through this Jefferson Regional Health Alliance, which again is, I think, one of our secret weapons that we always are so proud of in Southern Oregon, of being able to work together and understand and deal with some of the massive issues that we're talking about. This was in a newsletter that I received yesterday from former Senator David Durnberger in Minnesota. And in his newsletter, he focuses on healthcare reform. He reports, researchers report this week via Health Affairs that increases in U.S. healthcare costs of 3.9% in each of the last 3 years are the lowest in 52 years. It may be Obamacare at work, says Health and Human Services Secretary Kathleen Sebelius. It may be that patients can't afford services, say opponents. We need to raise our premiums, say some of our large national insurance plans in some states by as much as 20%. What's really going on, most experts will say, is health reform. Changes in how it's delivered and how is it paid for. The kind of changes that most good health systems have known were the only answers to public pressure to contain the increases in public spending on health care that are driving a good share of our entitlement spending. So again, without further ado, I'd like to give both Roy and Ann a little opportunity to talk about what does it mean relative to the Rogue Valley as to how healthcare is going to be delivered here in the future and how is it going to get paid for. So Roy, would you like to start?
Sure. Thank you, Bill. So as I look at this and try to put it into some context, for business, healthcare is about cost. And that cost 20, 30 years ago was relatively speaking a negligible part of your business expense. Most recently, it's one of the most serious inflated costs for business. For employees and for individuals, cost is also an issue, as well as access to health care. So there is a context around the need for reform. Right now, we spend nationally about $2.7 trillion per year on healthcare. That's about 17% of our gross domestic product. If that trend continued with our current rate of inflation, by 2020, we would be close to $5 trillion and over 20% of our GDP being spent in healthcare. Another contextual issue about why reform is needed, our population is aging, as we all are aware. Medicare, the number of Medicare recipients right now is about 43 million. By 2030, that number will be closer to 80 million people. Right now, we have 47 to 50 million people in the United States uninsured. As Bill mentioned, over 600,000 in the state of Oregon. The cost shift that business now is incurring is what has become unbearable. And the reason there is a cost shift, and for those of you who may not know what that refers to, is that Medicare, funded by the federal government, reimburses providers maybe as much as 80% of their actual cost of providing that service. Medicaid is probably closer to 70% of the actual cost. Well, you can't run a business in a deficit, and so that differential is made up by all of you, business, that are paying that cost of healthcare that isn't being covered through Medicare and Medicaid. So things that have been driving those healthcare costs in the past include fee-for-service medicine, that is being paid by the piece, by the service provided. That has incentivized everyone to increase volume of tests and procedures. There's been a lack of coordinated care between hospitals, between physician providers, between other providers of care, which leads to overtreatment. We have a huge administrative burden, a very complex system. The billing and verification process is extremely complex, which has led to increased costs of healthcare. I mentioned aging population. Chronic disease issues. Chronic disease actually encompasses about 84% of the expenditures of all healthcare dollars in the United States. And then finally, behavioral health issues and a lack of coverage for behavioral health issues. So how is the health reform, the Affordable Care Act or Obamacare, going to be funded? The cost is estimated, or has been estimated, about $1.1 trillion over the next 10 years. About half of that is going to come from cuts from providers. For example, the hospital industry will be accepting $155 billion of cuts in Medicare payments over the next 10 years. The other half is going to be from new taxes and from new fees. Interestingly, we said the $1.1 trillion I mentioned is the cost of this. The Congressional Budget Office has already calculated that that is probably closer to $1.7 trillion in cost. And if you look, if history is any guide, the first year that Medicare came into being, the estimates were off by a factor of 50%. So we are probably looking at a higher cost for healthcare reform than what has been predicted. The goals of the Affordable Care Act or healthcare reform are two. It's delivery system integration and insurance system changes. So delivery system integration includes things like linking performance, that is outcomes, patient satisfaction, and cost, to the payment that you receive and the incentives that healthcare would receive. Increasing integration between physicians, hospitals, long-term care providers, and other providers of healthcare in the community. Increasing access for healthcare services for the underserved. The healthcare reform should provide healthcare coverage for an additional 32 million Americans, about 16 million through Medicaid, and about 16 million through the health insurance exchanges. Insurance system reform includes things such as eliminating pre-existing conditions and lifetime and annual limits for insurance plan coverage. Also requiring coverage of preventive health for patients with no co-payments for those patients. The creation of health insurance exchanges, as I mentioned, to help access and to manage subsidized purchases by individuals and by employers. So that's a really brief synopsis of healthcare reform. Some of the challenges in Southern Oregon, and also opportunities, but mainly challenges in this context. For Southern Oregon, as opposed to the rest of the state, we have a payer mix that is a lot different from the rest of the state. I'll give you an example for hospitals. It's pretty similar, I believe, for physician providers. About 54% of our business is Medicare. About 15% is Medicaid. About 7% is self-pay, that is uninsured people. About 24% is commercially insured population. So think about the cost shift I mentioned earlier and the unreimbursed cost of care for Medicare and for Medicaid, and for self-pay it's even lower, anywhere between 0 and 10%. We are now shifting that cost to a smaller group of people in the commercially insured market. As I said, about 24%. That compares to Portland of about 35 to 40% commercially insured population. We have an aging population, as I mentioned, but even more so in Southern Oregon. About 20% of residents of Southern Oregon are 65 years of age or older. We're a retirement community, and we continue to grow faster than the rest of the state and the rest of the United States in terms of aging of our population. So some of the challenges, but also opportunities, would involve an integrated information system. That is actually having information systems that can be utilized real time by hospitals, by providers, to access information so that we're not duplicating services, so that care is better managed across the continuum. One of the challenges of that is the cost. Asante, for example, is spending about $57 million implementing an integrated information system over the next 3 years. Another opportunity, but also challenge for us, will be actually implementing what's called evidence-based practices, care protocols, best practices for medical care. Those are sound like easy things to do, but to get agreement on what is actually best practice for a particular care or issue that a patient has, and to get those implemented widespread throughout a hospital system and a healthcare system is a very difficult but necessary challenge. Another thing that is happening that I believe is an opportunity is true physician integration with healthcare systems, hospitals, and other providers, and also a shift then away from inpatient care and more toward outpatient care, which is a less expensive part of care. And then finally, I believe one of the biggest challenges, but also opportunities for healthcare, will be a closer relationship with the payers, with the insurers, and actually the sharing of risk for outcomes and for the cost of healthcare. So I'm going to turn it over to Ann Alfteen, who may tell you in a few minutes here some of the good things that are happening in Southern Oregon to address some of these issues.
Thank you, Roy. Let's see if we can move that. So I've got some slides here. And I wanted to thank both Bill for inviting me and Roy. It's an honor to be up here with you at the top of you guys here. Maybe a little bit louder. Closer, is that better? Okay. I'm Ann Alfteen, and I came here in 1998. My husband and I, right out of residency at the University of Iowa, and came and started our practice in internal medicine at the Medford Clinic. It closed in 2000, a year and a half later, and we started the Medford Medical Clinic. I'm no longer practicing there. I'm now doing project management work for the Jefferson Regional Health Alliance. I share that story because I want to show that I have some sort of idea of what it takes to run a business, and it's really challenging, a challenging perspective. So one of the stories I want to tell before I get into the slides is I was in Portland yesterday and talking to the CCO Oregon, which is the Coordinated Care Organizations. They took all the Coordinated Care Organizations, brought them all up to Portland, and we had some discussions about what was going on, and I talked about the Jefferson Regional Health Alliance. And I put up the slide about the Jefferson Regional Health Alliance, and I said, we're not from the county of Jefferson. That's actually a county north of Bend, and we are actually from the mythical state of Jefferson, and they did not know what that was about. So I got to talk about how we tried to secede from the nation with Northern California right before World War II, but it didn't actually happen, clearly. So let's see here. So the Jefferson Regional Health Alliance formed in 2005, actually, and I have written up there 2004. That's when Peter Senge was actually invited to Southern Oregon to have a very broad-based community discussion about health. And I don't know, were some of you at that? Were you guys at that? Bill, you were at that? I'm not sure if anybody else was there. A couple of hands. Okay, that's good, because I wasn't there, so I can tell the story as the myth as it was been told to me. But what was interesting is that Peter Senge is a big thinking person, a lot of systems thinking. And after a day of conversation, they came up with this chart, which looks really simple to me. But it's really deceptively simple, which basically says we start as healthy. We might have an acute illness, and then we'll move into chronic illness, and believe it or not, we all die. And so that, and you can see there's arrows that you can be healthy and stay healthy. You can be healthy, go to an acute illness, and then go back to being healthy. And you can possibly even moving from the chronic illness back into an acute illness, or even into health again. But those are all within the system of health. And the thing that folks that helped to start the Jefferson Regional Health Alliance realized, and one person in particular is Kathy Bryan at the Gordon Elwin Foundation. She was offering small to medium-sized grants to people in Southern Oregon around healthcare issues, some in the health, some in the acute stages, and some in the chronic stages. And she realized, and that board realized, that the effect of that was not as good as it could be. We need to start bringing together people to have conversations at a system level. Who are the people that are dealing with a chronic illness? Who are the people that are dealing with health? And elevate this to a community discussion. And that's why the Jefferson Regional Health Alliance was formed. It's a diverse group of healthcare leaders and thinkers. Both Roy and Bill are on this board. And again, I think they saw also that there was ways we could work together to do things that we couldn't do individually to help improve health for Southern Oregon. So, as Roy was saying, and before I get into the details of this slide, there are decreased dollars to deal with health and healthcare in the nation. And I'll get to some of those statistics in a little bit, but that gives you three options. You can stop covering people, you can stop paying for certain procedures to be done, or you can stop paying the providers. And that's really what you have to do. The governor and the legislatures basically said, no, we want a different option. We want you guys to do something more innovative than that. We want a triple aim. We want to improve care. We want to decrease costs and improve the patient experience. And we need to do this not by cutting people out of it, not by decreasing the amount of care people get, but we want to do this in innovative and collaborative and integrated ways because we know there's inefficiencies in the system. So, so the Jefferson Regional Health Alliance then can operate by convening different folks together around projects that help us to integrate healthcare. So we act as an incubator. Sometimes it's politically or financially really challenging for an individual organization to take on some of these projects themselves. And so when we have a community-based and more neutral group, such as the Health Alliance, it allows for projects to form. We also work as a networking support. We are based in both Jackson and Josephine counties, but we have people on these committees from Klamath and Curry County as well. JRHA is also a learning community. Again, it gives a place for a community and people to come together and say, all right, what worked, what didn't work, why is it working, why is it not working, why are we doing this? And then the JRHA funding is funded by its members, and that's about 10% of its funding. The members then are the seed funding, which allows us to get grants and sponsorships to do the different committees that we have. So the committee structure, so in 2005 when it started, we didn't have a committee structure. And in 2010, I got together and said, we want to look at these 4 areas. This is a critical time and things need to happen. We need to get some work done. And so they decided that end-of-life care, health information exchange that Roy mentioned earlier, the integration of mental health and primary care, and healthcare reform are the key critical issues. And over those 2 years, as project coordinator, I got it was a wonderful opportunity to work with incredible resources in our valley to bring people together to work on end of life. For example, the COHO, which is choosing options, honoring options. It educates our community and our providers on what are the options for end of life care, so we can have the conversations that we need to do and tell our doctors what we want at the end of life. Turns out 70% of people want to die peacefully at home with their loved ones, and only 30% actually get to do that. And so we need to educate folks about how do we get that done? How do we get our needs met in that area? And that's what COHO does. And then the Jefferson Health Information Exchange was a NIDIS that came from Asante and in purchasing very expensive technology, but the hope is that it will help to bring data to the physician to allow the best possible decision making, as well as information flow to allow the health information to move where the patient moves. It's also going to help us with integrating care between dental, physical, and mental health. And we're very excited. The Jefferson Regional Health Alliance, again, started 2 years ago with convening conversations around that. And just this month, we are implementing the first early adopter clinics. So it's an exciting time to be a part of that. The third part was mental health and primary care integration. And there's many different places where you could work on that. I mean, we've all read the papers. There's a lot of issues around mental health that need help. And I know our folks at Jackson County and Josephine County and their mental health teams are working hard to transform how mental health is happening. It's a challenging field. One of those specific pieces we're looking at is that, thank you, that the region, Oregon, the state of Oregon is #1 in deaths and use of opioid prescriptions. This is the Vicodin and the OxyContin. These things have street value and they're causing enormous havoc in our schools, in our workforce, and in our jail system and justice system. And so an opportunity, we realize that the physicians are actually becoming not intentionally drug dealers. And how do we set a community standard for prescribing opioids? So that was another initiative that we worked on. And finally, under healthcare reform, we did a lot of convening for helping people to come together to talk about how do we come together to form these coordinated care organizations to change how we integrate systems for the Medicaid population. We've also had conversations around workforce and education, and also at looking at the high utilization. There are some folks that use the emergency room in the hospitals way more. It doesn't serve them or any of the parts of the system. So that's what JRHA has done in the last couple of years. And here are some statistics about why this is important to you. So Americans make up 5% of the world's population and spend half of the world's medical dollars on the planet. And yet the life expectancy is near the bottom rankings for developed countries. So we're paying more for worse outcomes. And this slide shows us that the national healthcare expenditures per person from 1990 to 2018. And in 2008, we were at around $8,000 per person spending. And projections are that in 2018 will be upwards of, I can't read my number, 30-something, $13,000 per person. And what's interesting is that if you put that up against the per person, what their income is, it's $39,000. So that's just, we can't do that. I mean, so what is striking to me about this is this affects all of your employees and you as business people. And I know myself, I get insurance through the clinic that my husband runs, and it's terrible. And I'm a physician. It's not very tenable. Again, another slide showing if healthcare costs rose as much as medical inflation since the 1930s, my pound of coffee would cost $64. I would not be drinking coffee. It would be a sad day for Starbucks. So it's really easy to say, whose fault is it? And start pointing fingers. But we have to remember that this is a system issue and that we're all involved in this, and we can't point fingers. We actually need to come together and collaborate on it. So we are living in with finite resources in an infinite system. So this is a slide I show almost every time I meet with the Jefferson Regional Health Alliance, and they're kind of sick of seeing it, but it basically says why we need to come together. We need to do this collaboratively, and it sounds like many of you are already doing that. Some industries are better at this than others, and let's just say that healthcare is not known for doing this. And so reminding ourselves that we can be better together takes us looking at really seriously at turf issues and trust issues, and that's what this slide's about. Over time, we can develop more trust and integrate more effectively. And this is a reminder to say that together we can be the new architects and point a new direction for things. And here's our key components for what the last 2 years has been really helpful in supporting collaboration. Project lead experts, like Mark Hetz, the CIO at Asante, who really has this wonderful knowledge and skill set around health information exchange to help lead that. The stakeholder commitment development, bringing these folks to the table and helping them to talk to each other and build relationships. A torchbearer for just the idea that this should exist. Neutral leadership and holding space, I can't say enough about that one. There's been a number of times in a meeting where it's very clear that something needs to be said, and I'm able to say it because I'm a neutral party. I have no organization that I'm trying to promote one more than the other. A physician champion, and optimism. And this isn't, oh, let's all just get around and be happy kind of optimism. This is about holding a vision that it can be done, and it has to be done, and that the finances have to work. So I want to thank you for your time, and this is JeffersonRegionalHealthLines.org if you're looking for more information and some of the emblems of the folks that are involved. Thanks so much.